Okay, so who am I? So I am a pediatric nephrologist. I'm there in the middle. This is just before I got my CCT in 2018, so I've been practicing for 5 years as a consultant. I work at Birmingham Children's Hospital in the middle of England. It's a quaternary hospital for kidney and sometimes combined transplantation or multi-organ transplantation. I work in the NHS, so I don't need to pay, no patients need to pay for their treatment. And for genetic testing, now no departments need to pay for the test. So we just need to think of the test and order the test. All the other things are not our problem. And it's different whichever setting you work in. And what I'm saying to you right now is it's important to say, because this is the perspective I'm giving you, and this is how I'm able to organise the testing. So we had problems in the UK, and it was recognised around the same time that I became a consultant that we were not making diagnoses early enough. Patients had kidney disease due to a genetic cause, and they were waiting up to 7 years to get a diagnosis. Treatment pathways was delayed. There was a lot of chronic kidney disease that we did not have any treatments for, and we could not give any good coordination of care, support, or research without a genetic diagnosis. We had more other problems. There was no universal definition for rare disease. The incidence and prevalence of rare disease at the time in Europe was those diseases that affect less than 1 in 2,000 individuals. But that definition is different for America, is different for Asia, and therefore we didn't know what we were doing. Although individual conditions were rare, actually it affected 3 million people in the UK, and then there was a lot of cost associated with looking after those people. And that's why it's really important to try and get all those people that lived far away in England together and try and get a diagnosis earlier so we can try and put some prevention in place. Lots of patients have long-term chronic conditions and life-limiting conditions. They died before they got testing at that time. And that was only in 2018, not that long ago, actually. So we all know that rare disease affects about 80% of conditions that are genetic, and of those, right now we don't really know in our kidney the proportion of the patients that we see that are children and adults. We don't know exactly what proportion of them are genetic, but at the moment we think roughly 40% of children that we see in our kidney clinic, unselected, have got a genetic condition, we just haven't picked them up. And we think roughly 20% of adults with kidney disease of some form or another have got a genetic cause, but we haven't found it. So my experience, I'm going to give you one condition, ultra-rare condition, Bardet-Biedl syndrome. Bardet-Biedl syndrome, these children present with obesity, they always feel hungry, can't stop eating. Classical presentation they have retinitis pigmentosa, among other eye signs. They have extra digits in their hands and feet, and it was first described in the 1920s. And in the UK, the cost of hypertension, diabetes treatment, and renal failure was really high. And then the UK government said, why don't we get all the patients with Bardet-Biedl syndrome in one clinic? So they come to Birmingham or they come to London, Great Ormond Street, and we see them together. We know that there are lots of clinical diagnostic signs for BBS, and we know that before next generation sequencing, there were lots of different ways in which we found the genes, positional cloning, SNP arrays, etc. And we found that all those genes located to the basal body of the cilium. So the cilium is located on every cell in the body. There's it plays a part in lots of functions, whether it's embryonic development, cell signaling, or cell death. But the basal body was the time where all the BBS genes, they felt they were located in that area. And ciliopathy genes for nephronophthisis, etc., were located in other parts that made up the cilium. So in 2019, next generation sequencing was brought to the UK, and there was a gene panel for BBS. Currently, it is still a gene panel, but we use whole exome sequencing, and then we We look at those genes that we know cause BBS. In that time, this is just a graph of how whole exome sequencing discovered novel and rare disease. This is only in 2012, like data up to 2012, but that graph has carried on increasing. So now, in clinical practice, we're finding novel causes of BBS all the time. So for BBS, what's happened is that now that we are testing all of those patients that we think have got those retinitis pigmentosa, hand signs, those are the two main things. We're finding that we're getting the diagnosis earlier, and usually we can make a diagnosis within 12 months of thinking of doing the test. Now it's not 7 years to diagnosis. Most of the diagnoses we make, they're coming from the ophthalmologist actually, not from nephrologists. So they go to ophthalmology with night blindness or eye signs, and then they do the gene panel for the eye gene panel for retinitis pigmentosa, and that's how they get picked up. Or they get picked up incidentally because somebody has done obesity genes, so they're not being picked up just from the kidneys. The clinic numbers in the last 5 years have gone up fourfold because we've been making the genetic diagnosis. And now there's funding for those patients to access clinical care, to access the treatment that will help them to lose weight, Ozempic, and now they can access support groups and have financial support. We put all of our genotype information together as a UK group, and we found that BBS type 1 is the most common genetic change affecting the UK. BBS patients, that's the blue area here. We also found that most patients, adults, which is pie chart A, and children, pie chart B, have normal kidney function. Only a small amount have got chronic kidney disease or end-stage kidney disease. And we also found that by genotyping and confirming BBS, that we usually make the diagnosis of end-stage CKD or CKD in general within the first 2 years of the diagnosis. After that, if a patient age 10 comes to us with a diagnosis and they don't have any problems with their kidney function, now we know that they're not likely to develop anything in their childhood, so we can actually give some positive reassurance and prognostication based on their genotype. What was interesting was that genetically you could have Bardet-Biedl syndrome, but kidney-wise you could see a whole range of things. So it wasn't just ciliopathies, it was, you can have echogenic or loss of cortical medullary differentiation on ultrasound scan, you can have cystic dysplastic, hydronephrosis and Kakut, or other developmental abnormalities, or scarred or atrophic kidneys with hypertension. And now there are over 21 BBS genes. So they went from about 12 to 21 now, just through the use of next generation sequencing. So whenever I think of using a genetic test for BBS patients, I think of how clinically useful the test result is going to be. And this chart just gives you an algorithm for kidney patients on how you use the test to diagnose and how you use it to plan your therapies. So a genetic result for the BBS patients in my care helped to confirm, we looked at them and thought they had BBS, but then we were able to say what type of BBS they had. That's called clarifying clinical diagnosis. And then we could tell the BBS1 patients, if you have a normal ultrasound scan and you have BBS1, your chance of kidney involvement is very, very low. So now when they come to clinic, we can give them that kind of information, that level of genotype-specific information. The parents are already worried about their child losing their sight and all the other multi-system things, and we can say, okay, kidney care, I will look at your kidneys from far, but I don't need to see you every year. I can see you every 3 years, for example. The genetic result can also tell you what to look for in terms of extrarenal malformations. So some types of BBS has got an earlier onset diabetes, or they have got other clinical features and signs, and you make sure you look for them based on the genotype. And finally, if you confirmed a genetic diagnosis of BBS, you would be careful with your transplant planning. You try very carefully to avoid steroid where possible, because they will develop diabetes. We still use tacrolimus or CNI in our patients, but we make sure we can't deviate from our protocol, but we make sure we test very carefully for diabetes, early onset diabetes. So before we never used to check, and we never did HbA1c, but now we make sure we look at the urine every single time to screen for diabetes in these patients. So I'll just quickly move on to another group of patients that I look after. So I look after the primary hyperoxalureas. This is a patient, Nathan, who presented 18 months after gastroenteritis, completely anuric, and his kidneys looked like that. He had lots of stones. And when we looked at his sort of fungal pictures, he had oxalate everywhere, end-stage kidney disease. He's one of a twin, you can see here, and his sister was affected, but his sister was completely asymptomatic with the same variant. This is the family here. This is Nathan in the middle, smiling. He had a really difficult time. So he is patient A here. He went on to have hemodialysis and peritoneal dialysis to remove the oxalate and for normal end-stage management. He had severe hypertension because of the oxalate deposition in his blood vessels, and he had bilateral nephrectomy. He needed home hemodialysis, that's what the red HHT is. And in the end, he went for a liver transplant, cadaveric, in 2018. I looked after him during that time, and he spent 1 year in hospital because he was so hypotensive after the liver transplant. He had a really difficult period, and now he's gone on to have a kidney transplant. And we had a second patient very similar like that, but both with different genetic changes. And here we're talking about inherited primary hyperoxaluria, and with a wide range of clinical severity, as I said. Both patients had pH type 1. So pH type 1, this is a hepatocyte. And pH type 1, the AGXT gene is not working. So you get buildup of glyoxylate. Buildup of glyoxylate here. And lactate dehydrogenase or glycolate oxidase will convert it to oxalate. So you get lots of oxalate in these patients through that mechanism. There's a type 2 and type 3 as well. So when you want to make a diagnosis, in 2018, we made most of our diagnoses through stone analysis, urine, but you have to actually get the stone first. You have to go in and get the stone. Each time you go into the patient to do any kind of urological thing, you introduce more risk of more stone development. And so you have to balance the risks and benefits of doing that. The second thing is getting urine in an anuric patient is impossible. So you can't get a urine sample. So in this patient, we couldn't get a urine sample. We had to send off genetics to make the diagnosis. And in fact, we couldn't get a clear stone sample from him. He was too unstable at that time. And that orange bottle is the 24-hour urine oxalate sample. Unless you do the urine tests properly and they get to the lab quickly enough, you will get an abnormal result. So this is the problems we were having in my practice. The urine oxalate creatinine ratios. So you can see here the circles are pH 1 and the squares are pH 2. They can tell you somebody's got pH, but they can't tell you if you've got pH type 1 or type 2. And when you look at the urine oxalate creatinine ratios for all pH, pH 1, pH 2, pH 3, you can see they all overlap. So you can't tell the difference. You have to, oh yeah, thank you. Yeah. They all overlap here, and you can't tell the difference. So you have to use urine metabolic testing to look for the metabolites that will be pH 1, 2, or 3. But pH 1 and 3 can both show the same using these metabolites. So the testing wasn't great. What's the added benefit of doing genetic testing here? Well, there is a good benefit. So this is pH 1, 2, and 3 data. This is registry data from the Mayo Clinic. And it shows you that pH 1, 2, and 3, they all have stones. Nothing new, we knew that already. But pH 1 here leads to a faster decline in kidney function. This is renal survival here. pH 2 is in the middle and pH 3 is up here. So it tells us about the long-term outcome in our patients, and when they get the diagnosis, you can talk to them about it with registry data. This is a little bit more in detail. So here you're looking at pH type. pH 1 is the blue and orange. pH 1, pH 1, but they're different genotypes of those that you're looking at. What we know is that some genotypes in pH 1 give you a better kidney survival than others. So if you've got this 508 G to A, this one and this one, then you have a slightly better kidney survival advantage than if you have other mutations. And pH 2 is here, the best overall kidney survival. But why was this? So this is the pH 1 gene, AGXT gene. It shows you all the 11 exons from within it, and it shows you all the different variants we know that cause pH type 1. But the red variants here are ones where you can use pyridoxine. So if you give that patient pyridoxine, they are most likely to respond. You can't always tell if they're going to respond fully and get full function back of AGXT, but some patients do. The definition of pyridoxine sensitivity is you have a 30% reduction in urine oxalate creatinine, and that is sustained for 3 months. But you see, rather than waiting for the 3 months, you can have your genetic result and you can know that they will be sensitive to pyridoxine, and you can feel a bit more reassured. We in the UK start everybody on pyridoxine because it's cheap, and then we watch to see how many of them have that 30% drop. But we use the genetic results to help to guide the parents. Pyridoxine works by being a cofactor of AGXT and increases the paroxysmal import of AGT. So basically, it just, if the mistake is in the part of the gene, pyridoxine can help with the catalytic activity or the folding of the gene to make it work. When we look at all these genotype-phenotype associations, you can look up, if you know how to look it up and you start doing it regularly, you can look up your variant, and you can't see it on here, but you'll get a copy of this. You can tell whether they're B6 responsive or not based on registry data or papers like this. And you can also use the genotype as well as pyridoxine sensitivity to help to tell your patients when they will get symptoms, age of onset, age at diagnosis, and age at kidney failure. So B6 responsive patients present a bit later, they are diagnosed a little bit older, and the age at kidney failure is a little bit older. If you have a completely absent AGXT gene, you'll have a more severe phenotype here. These ones just tell you in between what's happening. This is just the same renal survival graph as before, just showing that if you're pyridoxine sensitive, you have a better survival than if you're pyridoxine resistant. And if you have a missense variant, you have better renal survival than if you've got no protein there at all. So now, how did this change my practice? So now we offer genetic testing to any patient that has nephrocalcinosis, renal stones, and if they And I'll tell you, because we now have a silencing RNA therapy in the UK that's now being licensed, the lab will give us the result within 21 days. We then go and do segregation analysis, the parental testing, and we can then offer testing to all family members. If there is a baby that's born to a family who are consanguineous and they already have PH type 1, if they are not symptomatic, so their ultrasound scan is normal, and their urine oxalate creatinine ratio also completely is normal, we have to be, in the UK, we have to be very careful about doing predictive testing. In patients and children that are not affected, you have to inform a geneticist and do it together. We also now started to talk about what if families want to have more children and they have the heterozygotes, so they carry PH1 but they're not affected. Lots of parents were coming to the clinic saying, I want genetic testing, I want testing with my partner, and I want testing for my children. But now we're able to use evidence-based to say, actually, we don't need it. We don't need that testing. And now we have guidelines for how we counsel our parents and what kind of testing we offer. So just coming back to Dipanjana's point about actionable genes, now for us as nephrologists, there are some genes that we have to take action. So even if we get a genetic diagnosis, it's not just to have a label now that, okay, this patient has PH1, we actually have to do something about their disease management. And primary hyperoxaluria is one of those actionable genes. And you know what I think is really good as a woman, and also something that I think is important for us because we want to prevent CKD, is that look at this bit here. There is such a big role now to empower women about their decisions about having a family, to make them aware if they want to do pre-implantation diagnosis, what things are out there. And also to think about kidney transplantation. Which diseases will recur in the kidney, and what are we going to do about it? So finally, how have I changed my overall practice as a nephrologist who does kidney clinics? So this is the way that I do kidney clinics in my hospital. This is my last slide. We usually get the family referral from the general practitioner or from other nephrologists or other people. We triage them, we do a virtual MPT, and we work out who needs to see them. Do they need to see the GC only? Do they need to see a nephrologist with some genetic support? Or do they need to be seen in the joint genetics kidney clinic where the geneticist is present? And that's how we handle our patient numbers. But now, since 2023, now we have subspecialty clinics that feed in directly to the genetics and they link in. So anybody with cystinosis and oxalosis, we feed into that clinic, and now we do national clinics for cystinosis and oxalosis. So other centres, they send their patients to us. And I discuss genomic testing at all key established kidney meetings. We all have histopathology meetings. And so I bring the genetics to the meeting rather than doing a separate genetics meeting for my colleagues. So for example, if somebody has SRNS and their histology shows FSGS, then I always say, have you tested for Alport? Okay? Other departmental meetings is the pre-transplant meeting. I go to that one and I make sure that we've looked at the genetic report. So if there's patient F1 beta, then I say, be careful with steroids, be careful with CNI, because this one is going to develop diabetes in the second or third decade of life, so they need screening for that one. And also I make sure the extra-renal testing for all these patients has been done. And then one thing I would recommend to you all to do is to try and set up something where you talk to each other. So what we have learned is that when the medicine came in for primary hyperoxaluria, our testing results were coming back 3 or 6 months after we sent the test for suspected PH1. But if you want to prevent the disease, and the siRNA can only prevent from that point, it can't reverse anything in the background. If you want to use that 3 months well, and the government will only pay for it if you've got a genetic result, then we needed the result to come here faster. So by forming the national group, we then had a bit more power to say to the laboratory, make it faster. That's how we changed it from 3 to 6 months to 21, within 21 days. And then finally, before I finish, now in the UK they're moving towards newborn screening. So newborn whole genome screening will happen. I don't know what the results are going to show, but there'll be a lot of worried parents coming to us because we will be making the diagnoses before the child develops the symptoms. I don't know if this will be something that will stay around or whether it will be something that won't work, but they've already started it. So now what we're doing is planning ahead. So now what we're making sure that in our team, we are making a pathway for any positive results. Making sure the genetic counsellors have got time to see the parents because that will take up so much of your time. And then we're making sure that we have separate clinics for tubular, glomerular, etc. So there are 11 conditions that they're going to pick up. You can't see on here, but one of them is oxalosis, cystinosis, some tubular conditions like renal tubular acidosis when the babies are really sick early on and you don't know what's going on. So that's where we are right now. So the way that we're moving. That's how genomics has influenced my practice. Thank you very much.